गुड मॉर्निंग। सेट सुगर। हाँ, मेरा है आज। हफ्ते किसी पर में। अरे आगे।
अच्छा, इस व्यू में रखना है सर या डायरेक्ट चले?
डायरेक्ट डायरेक्ट। और एक वीडियो है हम देखना। हाँ आगे। ओके, एक वीडियो करना है। वीडियो आ रहा है, मैं देखता हूँ। इसको जला के रखता है और ठीक। 6 मिनट तो फिर देख लो बस।
When you breathe,
आज का सर नहीं है क्या? नहीं है। जल्दी क्लास खत्म हो गई। ठीक ही हो रहा है ना? ठीक है। हाँ। नहीं है। बस ऐसे चल रहा है ना? ठीक है, सिंपल। Good morning, sir. May I start? Good morning, ladies and gentlemen. Today I'll be talking on obstructive sleep apnea and chronic liver disease, a complex relationship. And I'll be describing my talk in the following outlines. We all know that cirrhosis is associated with increased morbidity and mortality compared with the general population. And sleep disturbance affect a large subset of patients with cirrhosis, ultimately impacting their quality of life. Obstructive sleep apnea is a common comorbidity among these patients with cirrhosis, and untreated obstructive sleep apnea has a detrimental effect in patients with chronic liver disease. Now, what is obstructive sleep apnea? This entity may not be that commonly encountered by everybody and may not be known by many people. That's why we thought that we'll give a talk on this issue and its association with cirrhosis of liver. Now, obstructive sleep apnea is defined by the presence of repetitive episodes of upper airway obstruction during sleep, which is being shown in this video.
When you breathe, air travels down your throat, through your windpipe, and into your lungs. The narrowest part of that pathway is in the back of your throat. When you're awake, muscles keep that pathway relatively wide open. But when you sleep, those muscles relax, allowing the opening to narrow. The air passing through this narrowed opening may cause the throat to vibrate. That causes snoring, which many people experience. But in some people, the throat closes so much that enough air can't get through to the lungs. When this happens, the brain sends an alarm to open the airway. Most often, this is associated with a brief arousal from sleep. The brain quickly reactivates the muscles that hold the throat open. Air gets through again, and the brain goes back to sleep. This disorder is called obstructive sleep apnea.
Now, we have seen this video, what exactly is obstructive sleep apnea. Now, how we define apnea? Apnea means cessation of sleep, means I am not taking any breath. But in science, the definition is given if there is breath holding for at least 10 seconds. And there is another entity we have to understand before we go further into this entity. That is called hypopnea. Hypo means less, means my depth of breathing is less. How much less? Is 30% or less than the normal amplitude of my breathing. Along with that, there should be at least 3% fall in saturation. In that scenario, it will be called hypopnea. So at night, when we sleep, we may have apnea, that is cessation of sleep for 10 seconds or more. We can have hypopnea, that is cessation of sleep by 30%, cessation of breathing by 30% or more with 3% fall in saturation. And it keeps on repeating. So if there is an entity called apnea hypopnea index, we'll have to understand before we go further. So apnea hypopnea index is nothing but at night, say I sleep for 5 hours, and during these 5 hours of sleep, I have total 100 apnea and hypopnea. So 100 divided by 5, that is 20. 20 is my apnea hypopnea index, right? So this entity we should understand to go further with this talk. And so as I told, apnea hypopnea index less than 5, that is 0 to 4 is normal. A normal individual can have this, but if it is more than 5, then it's abnormal. So if between 5 and 15, it is called mild obstructive sleep apnea. Between 16 and 30, it is called moderate OSA, and more than 30, it is called severe OSA. So in these two MRI photographs we have shown over here, this is a normal upper airway, right? And here if you see, the soft palate is larger in size, tongue is large, and there is a subcutaneous fat posteriorly, and these things together, this person is more prone for getting apnea. So these are the people we should look for, particularly if they have cirrhosis of liver. Why? We'll see in subsequent slides. So we all have read Charles Dickens' novels. We all have been thrilled with that. And you know which was the first book he published? This was the posthumous papers of Pickwickian Club. This was published between April 1836 and November 1837, and that made him very, very famous. He's one of the famous British literate, even now very popular. And he described in his book a gentleman called Joe the Fat Boy. And we now, in the year 2025, understand that Joe had nothing, but he had a combination of both obstructive sleep apnea as well as obesity hypoventilation syndrome. I'll not talk about obesity hypoventilation syndrome. It's a huge topic, but our topic today is obstructive sleep apnea and its relationship with cirrhosis of liver. Though Charles Dickens had described this entity more than 100 years back, and this was known even much before that, but the term sleep apnea syndrome was described only 50 years back by this famous paper by Christian Guldenholt in Annual Respiratory Review. And there he is described that apnea should be called when there is cessation of sleep more than 10 seconds. And that definition, even today after 50 years, it stands. And since then, in the period of this 50 years, this has been reviewed by this year's literature, and there they shows that obstructive sleep apnea exacerbates liver disease, and it should be looked for in patients with cirrhosis of liver, and if present, it should be treated. And the thing is, how common, now we are understanding obstructive sleep apnea, but how common is the prevalence in the world and in India? Well, in this, actually it's very difficult to have a total thing because definitions are different, to get so many patients are different. But in this Lancet Respiratory Medicine 2019 review article, they did study of all the literatures available from different countries, and they said that year probably 936 million people had obstructive sleep apnea. And if we take that thing into account, That means after 6 years, in 2025, there must be more than 1 billion people who are suffering from obstructive sleep apnea. As we understand now, that is in 2025, the world population is around 8.2 billion. So more than 1 billion means 1 in 8 person in the world is suffering from this entity, that is obstructive sleep apnea. And India, again, India, the data is poor, but it is estimated that in India, at least 100 million population, that is more than 10 crore people are suffering from obstructive sleep apnea. So it's a huge, huge burden. Now, what are the risk factors for obstructive sleep apnea? Many of the things we know. First is obesity. If the BMI is more than 30 kilogram per meter square, and as we understand, this is associated with cirrhosis of liver also, or NAFLD in many cases. Then increased neck size. If the neck is wide, more than 17 inches in male and more than 16 in females, then there is a possibility this patient have obstructive sleep apnea, and it is more common in males by 2 to 3:1. And there, if the patients have any abnormalities of the upper airway, like large tongue, if there is a tonsillar hypertrophy or deviated nasal septum, so this can give rise to again this obstructive sleep apnea, and there may be some genetic disorders, though very uncommon, and hypothyroidism, polycystic ovarian syndrome, acromegaly. This can also these are also risk factors for OSA. And alcohol, sedative, and hypnotic use also can give rise to this syndrome. So that's why when we treat them, we tell avoid these things, which I'll be showing in the subsequent slides. Now, what are the clinical presentations? The patient, as we saw in the video, will have loud habitual snoring. There will be witnessed apnea. Who will witness? Obviously, the bed partner, the spouse. There will be nocturnal awakenings many times, gasping or choking episodes during sleep. There may be nocturia, nocturnal sweating, unrefreshing sleep, morning headaches, excessive daytime sleepiness, automobile or work-related accident. This is an important thing. See, if a driver has obstructive sleep apnea, many of the drivers in India, they do not get good sleep, so they feel drowsy at daytime, and they are vulnerable to cause accidents, causing risk to their own life or the other people. So in USA and some of the Western countries, there's a law that if a doctor finds that the driver is having obstructive sleep apnea, then they have to inform the licensing authority that this person has obstructive sleep apnea, and his or her license should be withheld for some time, and this person should be treated, and after treatment by whatever means, CPAP or whatever, as we see subsequently, the patient improves. Then the doctor again writes back to the licensing authority. Well, the OSA is under control, so the this license may be renewed for this particular driver. Now, how we clinically see whether the patient has obstructive sleep apnea or no. So one of the common symptoms, as I shown, is increased daytime sleepiness. So this is one of the old marker for looking for whether the patient has increased sleepiness and whether the patient has obstructive sleep apnea. So here there are 4 types of situations where the 8 situations are given, and in this, whether the patient either goes dozing, sleeps, or whether the patient doesn't sleep at all. So 0, 1, 2, 3, and these are the things described, that is sitting on reading. That time they may feel sleepy, watching some boring TV program, and like sitting in a car without any brake. Then particularly one important thing is you are in a car stopping for a few minutes in traffic red light, and then you doze off. So then very, very risky that you may land up in trouble with accident. So total scores can be 3 multiplied by 8, so 24. Out of that, if the score is more than 11, it is a very high risk for obstructive sleep apnea, and the doctor treating this person has to intervene. Now, there are other 2 questionnaires available. The second one, it is the Berlin questionnaire. It looks complicated in the slide, but I am trying to make it simple. The questions asked to the patients are, do you snore? And you should ask the question along with the bed partner or the spouse. So you ask, do you snore? Do you quit breathing during sleep? Do you feel tired or fatigued after sleep? And do you fall asleep while driving? So out of this, if the where it is risky, if the more than two categories are positive, again this person may be having obstructive sleep apnea, and you should look for should confirm and then treat this patient. The other questionnaire is top bank questionnaire. That is an acronym of these 8 things. That is snoring, tiredness after sleep, observed apnea during sleep will be told by the spouse. As if the patient has blood pressure, this thing as a clinician will have to ask them. BMI, if we record more than 45 per meter square, age more than 50 years, neck circumference. We have already discussed earlier that more than 17-inch in male and 16 in female. And gender, I showed that it is more prevalent in male. So if one is male, then more risk to this. And if it is scored out of this 8 is between 5 and 8, this shows that there is a moderate to severe risk of OSA and one has to intervene. Now, what are the indications for evaluation? I showed those questions. Obviously, the patient, if it's obesity, that's a very high risk factor for OSA. Then cirrhotic patients all should be evaluated for OSA, particularly if they are obese. Then hypertension, coronary disease, cerebrovascular accidents, diabetes, pulmonary hypertension where you do not find any other cause. And sleep-related automobile crash already we have discussed in details. And another important thing is temperature is there. Preoperative anesthesia evaluation. Why? Because we know about Mallampati score. I'm not going into the details. So these are 4 grades. These are severe grades. So here intubation is very easy. But here, when hardly you can see the uvula or the inside the throat, then it's very, very difficult to intubate. And here, during perioperative time also, there may be complications. So in these cases, unless there is an emergency surgery, you treat it with CPAP or other modalities. After the patient is improved, then you do the surgery. Now, how the polysomnography is done? This is Kunal, our junior technician. So you use different, like we did the EEG, ECG, so many leads are put. And no pin is used. It's just put one lead is there, like we do ECG, and over that you just paste it. So what are the things? Thermal sensor and the mouth to detect mouth and thermal sensor to detect the apnea, nasal pressure inducer to detect hypopnea. I told that there's more than 30% fall in intensity of the breath. Then chest wall and abdominal movement detection things are there. And pulse oximeter they are done. ECG is recorded. EOG, electrooculogram is done. Chin EMG done to see if there is any breathing. And of course, EEG. EEG is it's closed over here. And this is done in our system. We have a video recording system. So the patient comes, say at 9 o'clock or 10 o'clock, sleeps in the sleep lab after all this lead has been put, quietly sleeps, and it's being recorded in the computer. And these are attendants sitting over there. And the technician stays in the next room, looks for if there is any abnormality. And after the sleep test is over, next day the patient can go back and we evaluate the whole reports in the computer. During the process, if the technician, there are 2 ways this sleep study can be done. One is the simple sleep study. Then if you find there is a obstructive sleep apnea, the next day you call the patient and do sleep apnea titration. Titration means at what pressure the OSA is being abolished, right? So for that titration you will have to do, so you may call the patient second day. So for the patient to come second day is cumbersome. So there is an entity called sleep night study. What is done? If the patient is sleeping in the sleep lab for 8 hours, first 4 hours you do the test and look for whether there is any evidence of obstructive sleep apnea. Like in this patient, I'll show in the next slide, it's a bit congested, but you can follow probably that there is sedation of leads, the abdominal and thoracic, the leads, they are not moving properly, and there is a awakening of the patient. So as I showed in the previous slide or even the video, so this patient has obstructive sleep apnea. So there is the indication for doing the CPAP titration in these patients, right? So the CPAP titration should be done if OSA is detected, but after 4 hours of sleep. So here is one polysomnography which I showed in the previous one. You can see better that there is a cessation of the airflow and there is a arousal. So here are the leads. The first, these leads are EEG, electromyography, that's the chin. Then the two leads are put on the tibia. Why? Because restless leg syndrome, we understand, is one of the causes of insomnia or cause of sleep disturbances. So for that, it is put ECG lead, nasal and oral, I have already shown, and chest and abdomen, I already shown. And here there is a cessation of airflow, so this is obstructive sleep apnea. And immediately after that, as I showed in the video, the person has arousal. So in OSA, it keeps on recurring repeatedly, and you understand, if you are not able to sleep properly, bar would try, so there is abnormalities with the hormones, there is oxidative stress, and that gives rise to multiple diseases we'll see later, and that include both liver fibrosis as well as cirrhosis of liver. So cessation of airflow is followed by OSA followed by arousal in OSA. This is another one I've shown here. The patient is breathing normally, whereas in between there is obstructive sleep apnea repeatedly, and there is fall in oxygen saturation also. Classical of a obstructive sleep apnea who requires to be immediately treated. Otherwise, there might be problem. So what are the
Dr. Bhattacharya, can you go to previous slide and the previous?
Sorry, sir.
Previous to this. Yeah, so what is the index? The apnea, hypoxemia. What is the index in this? It is almost 20 seconds.
Sir, it actually apnea index is measured for the whole sleep study is done for the.
Now in this one, it is 20 seconds.
Sir.
What would be the?
Sir, 20 seconds is too less a period, sir.
Too less.
Too less a period, sir,
Okay.
because you have to record the sleep for at least 6 to 8 hours. Measure the total number of
Okay.
apnea and sleep apnea, divide by this thing, sir. So, what are the pathophysiologic mechanisms and consequences of obstructive sleep apnea? There is sleep fragmentation, we have already shown, and this can cause like to crashes like vehicular accidents. Then there are the neurocognitive effects. The patient's cognitive function deteriorates, the executive function deteriorates, the patient remains confused, and then there is hypoxemia. Hypoxemia causes so many problems: sympathetic surge, hemodynamic effects, then oxidative stress, inflammation, endocrine dysfunction, hypercoagulability, and endocrine dysregulation. And this can give rise to diabetes mellitus and insulin resistance. And insulin resistance, as Dr. Sarin sir keeps telling, that this is one of the forerunner for liver disease, that is both the NASH as well as fibrosis and cirrhosis of liver. So this is important factor. And of course, it has got effect on the cardiovascular system, that is hypertension, coronary artery disease, congestive heart failure, arrhythmias, CVA, pulmonary hypertension. Actually, many a times we may not be noticing, but a person, particularly if there is no cause for secondary hypertension, you are giving drugs, one drug, second one, third antihypertensive, still the BP is not getting control, you must keep in mind that this person may be having OSA and you should evaluate food. And two patients I have seen, I have done sleep study, found OSA, given CPAP, and then requirement of antihypertensive has come down drastically. So what is the treatment? I just in brief touch upon this. Obviously, first thing is weight loss and avoid alcohol and sedatives. Earlier I've shown, include sleep hygiene. Position therapy, it is proposed, but I don't know how much useful it is. What is done is you take a tennis ball, put it to the backside of the upper kurta or shirt what the patient is putting on during sleep, so the patient do not lie on the supine, because if one lies supine, then the number of OSA or this apnea index increases. If you lie lateral, it is less. So this way they try to reduce the rates of apnea index, but this is definitely not a definitive treatment. Now, the definite treatment is CPAP, that is continuous positive airway pressure. In market, it comes in different modalities, but I don't think there's too much of a difference among this. Other things which are available is mandibular advancement device. It's a device made by orthodontists, a dental surgeon specialist in orthodontics. They prepare this. What it does, it advances the mandible. इसको आगे ले आता है, and it is useful only in mild and moderate sleep apnea. Means those who have got 5 to 15 AHI, there it is useful, but this is not a primary indication. If the patient fails to use CPAP or doesn't want to use CPAP, then only you should go for this one. Some people may benefit. Expiratory resistant device is more of a for description, but not much useful. They put some valve sort of thing, and they say that it's supposed to increase the pressure in the upper airway and stop closure of the upper airway, improving sleep apnea. But I don't think it's very useful. Bariatric surgery, for obvious reason, for morbid opacity, it is useful. And upper airway surgery in selected cases. What are those? Like if someone has a deviated nasal septum, large tonsils, or in certain cases, not very popular in India, but in Western countries, what they do they do dynamic MRI. While the patient is sleeping, they do dynamic MRI. I'm not showing the video over here. I've not seen it being done, but it is described in literature. To do a dynamic MRI and see where all there is a obstruction to the airway. And after that, the ENT surgeon, what they do is they ablate those areas where there is an obstruction with laser. So again, the description is some cases it is useful, but again, first treatment is CPAP. And if the patient do not tolerate it or it is not that useful, then only you go for this high-tech thing. And the next one, of course, is Tirzepatide, Mounjaro, the one-lead drug so-called. It is mainly recommended for, we all know, that for obesity and diabetes. But after this surmount with a trial published in NEJM in 2024, the US FDA has approved Tirzepatide for obstructive sleep apnea as well, but in India it is still not approved, though some of my friends use this thing for USA also. Now coming to the this CPAP machine, he is the gentleman, Dr. Colin Sullivan, who invented CPAP in 1981. He is from Sydney. And he was, from his young age, he was interested about this entity of the obstructive sleep apnea. And in 1960s or 70s, what they used to do is they used to do tracheostomy. In severe cases, like I saw that Joe the Fat Boy described by the Charles Dickens. So in those scenarios, they used to do tracheostomy. And you understand, to live with a tracheostomy is not a very, very comfortable thing. So he did research on dogs initially, and subsequently he published his first paper in 1981, where he showed in 5 patients that these were the patients with CPAP machine. He made his own type of machine. With that, the patients have improved. And later on, he started a company with his financier called Resmed, and this is still one of the most popular brand. I'm not representing them. It's one of the popular brand along with Philips for all these devices, CPAP, BiPAP machine, and oxygen concentrator and all. So this is a CPAP machine, one of the prototypes, and this is a BiPAP machine. So whom to give CPAP? Those who are simple OSA and not too much obese or do not have any comorbidity like COPD and all. If COPD is there or patient is very obese, in that scenario, you have to give BiPAP. So what is the difference between CPAP and BiPAP? In CPAP, you are giving a continuous pressure. Continuous pressure you are giving, no fluctuation, unlike normal respiration. In respiration, there is an inspiratory pressure, there is an expiratory pressure. So here, simply your aim is to keep the upper airway patent. But that is not useful in patients with COPD and OSA or very obese patients like the Joe the Fat Boy. There you have to do BiPAP. What is BiPAP? It is like normal respiration. You are giving more pressure during inspiration and less pressure during expiration. So there are 2 pressure parameters. And how you deliver? You deliver by the mask. Mask, at least are 3 types useful for this. One is full face mask, one is nasal mask, and this is called nasal pillow or nasal insert. Out of all 3, I find this is more comfortable for the patients, but it's a bit costly. And when the titration is done, and subsequently if you find the patient definitely requires to be treated for OSA, then patient should be tried with all these masks. And if after a few days, let the patient decide which one he or she wants to use. Now here I am showing that After the use of CPAP, this lumen, the upper airway lumen is gradually increasing in size. The more the pressure, the more increase in the size. Now, what is the impact of OSA in liver injury? We all know that OSA triggers chronic intermittent hypoxia, which is crucial contributing factor to liver injury. And nocturnal CIH induces oxidative stress and cytokine production, which has been implicated in the pathogenesis and advancement of liver fibrosis in both MSLD as well as NASH. And results of a study assessing the impact of CIH and morbid obesity on liver damage demonstrated that patients with a BMI of more than 45 displayed significantly more severe steatosis and fibrosis. And studies have also demonstrated that heightened occurrence of OSA occurs in MSLD. So what is the mechanism for obstructive sleep apnea? How it occurs? This has been described in the latest published journal in clinical gastroenterology this year. So what happens is the patient has obstructive sleep apnea and there is chronic intermittent hypoxia. So that causes obstructive stress and decreased blood flow. This causes hepatic ischemia, and there is an increased expression of hypoxia-inducible factor 1 alpha. This causes inflammation. There is activation of the lysyl oxidase in the liver, and there is activation of hepatic steatotic cells. And this gives rise to differentiation of stellate cells into myofibroblasts, and there is collagen deposition, there is extracellular matrix deposition, and it ultimately gives rise to liver fibrosis and cirrhosis of liver. And what are the inflammatory marker? One is glucose. The impaired glucose induces a risk for sleep disturbance because there is higher fluctuation of the glucose level. And that impaired tolerance causes autonomic dysfunction, and it may be associated with melatonin and cortisol rhythm. I will know that melatonin is very important for our sleep cycle. If the melatonin level is high at night, the patient is unable to sleep. So this abnormality of melatonin, and melatonin is metabolized by liver. So if there is a metabolic increase in melatonin at night, the patient may have sleep disturbances. Another two things which have been described is IL-6 and TNF alpha. Higher serum TNF alpha and IL-6 has been observed in 57% of the patients who are poor sleepers. So this may also be one of the factors which causes obstructive sleep apnea, particularly in cirrhotic patients. Another theory proposed is the two-hit theory. We all know. First hit is fatty deposition in the liver, and then obstructive sleep apnea. There is intermittent chronic hypoxia, which causes this reddish oxygen radicals. They cause damage. Then HIF, I showed in the previous slide, that causes fibrogenesis, and LOX1 causes endothelial injury, and all these things combined together may precipitate NAFLD. And what are the risks of OSA in cirrhosis? It has been observed that cirrhosis is an independent risk factor for developing obstructive sleep apnea. And individuals with cirrhosis has a higher risk of developing OSA, that is around 40% in comparison to the general population. And how does it occur? How increased risk of are attributed to this sleep apnea? The mechanism is alterations in respiratory muscle function, disrupted sleep patterns, and elevated abdominal pressure, which is commonly observed in patients with cirrhosis because of tense ascites and all. Now, this is one of the study. Again, they try to find out how common is OSA in liver disease, and they showed that it is around 42.9% in the study. In the same study, they also observed a higher risk of OSA with larger necks. I've already showed in the initial slides. And second factor they found is that those people who sleep less than 8 hours, they are also prone to develop OSA. And they also noted that the association between OSA and cirrhosis is independent of age, gender, tobacco use, and the cause of cirrhosis. So this is another study where they did a study of the NAFLD patients and their fibrosis risk by doing ultrasound. This is a retrospective analysis. They had 133 NAFLD patients, and they found that 37, 29, and 32 patients had mild, moderate, and severe obstructive sleep apnea, respectively. The other studies have also showed that OSA may pose liver injury independent of obesity. And while obesity remains the strongest phenotypic risk factor for both OSA and CLD, findings show that hypoxia appears to directly contribute to liver injury and the development of progression of CLD. Hence, early identification of OSA plays a crucial role in mitigating the progression of liver injury and cirrhosis. Studies have explored that there is a relationship between severity of liver disease and occurrence of or intensity of OSA. A study from Taiwan has showed that there is a higher incidence of liver disease in individuals with OSA. And in the OSA group, they found that the higher incidence of cirrhosis is more in comparison to the people who doesn't have this. Now, how useful is CPAP in patients with cirrhosis? Well, CPAP ventilation has been demonstrated by several studies that it is useful. It enhances the quality of life, it reduces mortality, and it also lowers the aminotransferase levels in individuals with OSA and MSLD. And undiagnosed OSA can exacerbate attention deficits in cirrhosis of patients. Use of CPAP in these patients has shown promise in improving executive function regardless of the type of cirrhosis. Now, how effective is CPAP therapy in patients with OSA? This is a review study published in 2018, and they showed that CPAP treatment is beneficial if used not for 1 or 2 days or 3 days. This is not a fancy item. It has to be used for a longer duration. And this is the meta-analysis of so many studies they did, and they showed that it has to be used at least for 3 months or more. And the better results you get if it is used for 1 year, 2 years, even longer, for longer duration. Then there was a study at Taiwan. This also showed that at least 6 months of CPAP therapy reduces the cumulative incidence of liver disease in patients with OSA. And this of developing liver disease was notably lower among OSA patients who were treated with CPAP than without treatment. Another study showed that is a significant decrease in liver steatosis compared with baseline as determined by liver ultrasound during the first year of CPAP treatment with OSA. The results of a study conducted in Taiwan revealed that, I have shown this study already. All patients with liver disease should be screened for sleep disturbances, especially if their BMI is more than 30. This I showed in one of my previous slides also. And if possible, one can do those stop bag or Berlin questionnaire, though it's a time consuming in a busy OPD, it may not be that easy. They were more used for research purposes. The patients who screen positively should be referred for a sleep study and offered CPAP therapy if found indicated. And significant improvements in MSLD parameters are likely to be observed only after more than 3 months. I have already described in the previous slide. And this paper, this 2025 review article published in Journal of Clinical Gastroenterology, they proposed a screening strategy for sleep apnea in advanced liver cirrhosis. They said that all patients with liver disease and BMI more than 30, they should be evaluated with this stop bag or Berlin questionnaire. And if it is high, in that case, proceed with the polysomnography diagnostic technique, and obviously if found positive, you treat them. Whereas if the patient is not that obese but have other features of obstructive sleep apnea, which I have already described, then also use this questionnaire. And if it is low, in that case, you may not give the CPAP therapy. You just keep the patient under observation and ensure that the patient doesn't get their weight increased and later on develop obesity and OSA. Now, what is the role of artificial intelligence in OSA? This is a study published this year from All India Institute of Medical Science, Delhi. And there they showed that AI is useful for efficient OSA care. And they did a meta-analysis of so many studies published since 2019 till 2024. And there they found that artificial intelligence is useful in polysomnography automation, in treatment optimization of the patients, and also in monitoring the patients. Now, how accurate is the AI in diagnosis of obstructive sleep apnea? This is another review article published this year, and there they showed that earlier models it was 67% accurate, but present models are supposed to be 98% useful. But there is a rider over here. These studies have been done by deep learning methods where you know there is black box, means how they have done the study, the whole thing is not published. So this has to be taken with a pinch of salt. Now coming to the ILBS data, the sleep study done from February 2013 to October 2025, and total 352 patients were studied, and 261, that is 74% were male, and 91 were female. And out of that, 38.9% patients had OSA, and these patients did not have OSA. And this is the comparison between OSA and present and OSA not present. I'm grateful to Dr. Ankit who helped me in compiling this data. I myself may not have been able to do it. So here we find that age, gender, AST, ALT, lipid profile, glucose, thyroid, these are not that useful, but what is statistically significant is body mass index. In people with OSA, as understandable, the BMI is high in comparison to those people who do not have high BMI. And CTP score also is higher in OSA patients in comparison to those who doesn't have OSA. And when we compared with the comorbidities, as we showed, the diabetes, hypertension, CAD, and dyslipidemia are comorbidities, but there is no statistical difference between OSA and non-OSA patients. And again, when it was put into multivariate regression analysis, the BMI again shows that it is statistically significant, and CTP in univariate analysis, it is statistically significant. So we have made a protocol for OSA patients in cirrhosis. The number one is cirrhotic patients with sleep complaints with a neck circumference more than 43 centimeter in men and 31 centimeter in women, and BMI more than 30 with no hepatic encephalopathy should be referred for polysomnography or sleep study. Diagnosis of obstructive sleep apnea should be made if they have apnea-hypopnea index more than 15 per hour, or apnea-hypopnea index more than 5 hours with features of obstructive sleep apnea like excessive daytime sleepiness, waking up from breath holding, gasping or choking, or the breath partner or the spouse telling that the patient snore loudly, there is breathing interruption, or both. Cirrhotic patients with OSA should be prescribed and encouraged to use CPAP machine while sleeping at night for a long period of time. It should be for more than 6 months or maybe years. And another thing is, some people at night use it just for 1 or 2 hours. It's not useful. At least it should be for 4 hours. But better not to tell the patient that 4 hours. Then the patient, instead of 4 hours, use it for 2 or 1 hour. We have to tell the patient that use it the whole night. So, ladies and gentlemen, to conclude, obstructive sleep apnea is common in cirrhotic patients. Clinicians should look for symptoms and signs of OSA in these patients. Patients with features of obstructive sleep apnea and chronic liver disease should be referred for sleep study. Encouraging healthy sleep habits and utilizing CPAP therapy have demonstrated their potential in alleviating sleep-related symptoms and potentially preventing the worsening of cirrhosis. Emerging evidence suggests that incorporating CPAP into the care of patients with moderate to severe OSA in liver disease is crucial to minimize the progression of liver disease. Thank you.
Thank you, Dr. Bhattacharya, very educative. And a few comments from my side. What is the number of patients who received CPAP in ILBS after the sleep study? We had 38% who had sleep apnea. So did we prescribe them?
We routinely prescribe, but exactly how many are using, I do not have data, sir, for that.
We should, because at least
Yes,
I have not prescribed. So
Sir.
once the sleep study comes,
Sir,
we think that it is now the job of pulmonologists.
sir.
So we will also, we are educated, we will advise patients to use CPAP.
Yes.
Second is if patient has ILD, which is also very common in obese cirrhotics. So what do you do for ILD? Do you look into ILD plus sleep apnea? Any problem in that?
You are talking about interstitial lung disease?
Yeah, interstitial lung
Sir,
disease.
interstitial lung disease, that pulmonary medicine treatment is two, sir, pirfenidone and the main use is pirfenidone and nintedanib. So both causes hepatotoxicity. So we cannot give that. So
No,
CPAP,
question is if a patient has ILD
sir.
and also is obese, will you do sleep studies and what will you advise?
Yes, sir. We will do a sleep study, and if the patient requires CPAP or BiPAP, we'll give that, and with that, we'll give oxygen also if the patient has hypoxemia, sir.
Any other comments or so?
Bhattacharya sir, I also had so it's a very good presentation. I just wanted to know about, because you showed us the cross-sectional data, but what is the data on the reversibility of OSA with the weight reduction strategies? What is the effect of OSA on fatty liver?
Actually,
Because
I don't look for
hypoxia is also known to be one factor in patients of NASH, which affects the even outcomes of NASH. So that's also very important part, how we treat OSA as an organ in these patients, and the reversibility because I have seen my patients getting better off CPAP with weight reduction.
Yes, yes,
So
definitely. This is
it
useful.
was also a reversible factor.
Absolutely. It's a very useful and reversible. You must prescribe CPAP or BiPAP depending on the requirement.
Sir, I have a question. You showed the data, but in normal weight cirrhosis patients, the incidence of sleep apnea is more than the general population or not? If so, what is the mechanism? And the second question is,
Hold on. I could not get your question properly. Just say slowly.
sir, in normal weight cirrhotic patients,
Normal weight cirrhotic patients, right?
the incidence of sleep apnea is more than the general population or not?
Yes,
So-
it should be. I don't have
So what's the
data for
mechanism?
that, but it may be more. But I can look from that point of view.
If so, what is the mechanism?
The mechanism same, the hypoxemia. Acha, this is the second one that Sir is telling something.
No, his question is, Dr. Bhattacharya, if you have no BMI is normal and they are still cirrhotic, and do they have sleep apnea also?
They may have.
Do you have data on that? That's what
Actually,
he's-
even a thin person can have obstructive sleep apnea. So there are multiple factors for that. You don't have to be obese to have
No, in
obstructive sleep apnea.
cirrhotics, do we have data on that?
I do not have
you have to
data.
dig in. You have to dig into that.
I can study
one
from
is-
that point of
one is-
view. We can
So actually, just a general comment that since 1990s or so, we've been doing a lot of studies where I was in there in MEMC. And we did find with use of these machines, people who have developing diabetes got reversed. People who had hypertension got reversed.
yes, definitely.
And these were part of lifestyle modifications plus use of this machine. So the only challenge at that time in the beginning, sir, was about the machines were not so good. And people had problem with the compliance, but now they are such auto CPAPs and all available. So the compliance and everything is much better, and it's completely unrecognized and under-recognized condition. We having lost a colleague of ours because of this illness. He was a thin and slip faculty at AIMS, and he died of a roadside accident because of this disease. And it was not, it was a subsequent thought about it. So just a general information that we ignore this, but it is very important.
True.
Two more messages that everyone who snores is not OSA.
Yes,
So you have to define that as well.
true,
And do not subject everyone to a sleep study.
true.
But if patient comes to you with symptoms of fatigue, morning headache, even if he doesn't have much daytime sleepiness and have other comorbid conditions, you should investigate them and talk about that. I have a small comment, Dr. Bhattacharya, is about, we were earlier using Epworth sleeping scale, which was very convenient. Now these two questionnaires are more critical. So now the definition of an AHI with, up to 15, we generally do not recommend using a CPAP,
Yes,
but doing other measures. But there are a category of subgroup who have already 2 or 3 comorbid conditions. You would like them, even with that index, to use it for a few months
true.
and see the improvement. So just not stick to that rigid attitude that you would not use that.
Absolutely.
And 15 to 30, of course, it is very, very critical. One more last point is that there are multiple factors in patients with cirrhosis. Of course, the main triggering factor is hypoxia, but there are multiple other things in terms of their nutrition, their albumin. All those factors do contribute to this, genesis of this issue in that, and quite, under recognized. That's my.
Thank you, Dr. Daga. Thank you, Dr. Bhattacharya, sir. Thank you very much. A big round of applause for you. ILBS is very lucky last week. Last week was very good for us, and I got these messages. So please do clap for SC Agarwal oration to Dr. Ekta. Is Ekta around? She got this award. Big round of applause for Ekta. You make us proud. Harsh got in the Korean meeting the best oral presentation. Harsh, are you around? Must be working. Big round. And Anupama got this award in the sorry. No, Anupama from the MCM department. She got this award in China. If she is around, a big round of applause. And in the night, I got this message from Seema. In the pediatric conference just finished yesterday. So they got CP Mittal Award, second award in plenary, poster of excellence, poster second, voice second, and SRS award. So almost all the awards of
The SRS is the Rising Star Award, which we
Rising.
have been getting for the last 3 or 4 years in a row. And the CP Mittal is an award which a young investigator gets, and we have bagged all except 2. Vikrant will tell us how many, and maybe 2, we've bagged about 10. 10, yeah, we've taken 10 and 2 we lost somehow, but we've taken 10. So,
very good. We're very proud of all our colleagues.
so I want the boys to stand up. Where is Samanvay?
Where is Samanne?
Samanvay?
Okay,
Yeah.
very good.
Stand up. And this girl, Rising Star, she's passed out from us last time only. So she got 3 awards, including the Rising Star.
The residents are very good mentors. A big round of applause for mentors also. Thank you all. And we have a visitor now with us for a few months. Pierre, introduced from Spain. So everyone will know the Spanish in few months. You will learn Hindi and we'll learn Spanish. Yeah.
Namaste. Namaste. Thank you, everybody. I came from Palma de Mallorca, Spain. It's an island near Barcelona. And I'm very glad to be here and learn about everything about everybody and learn a little bit Hindi. I already started, so if you want to teach me, I will be very glad. Thank you very much.
I see Dr. Rastogi here. Is there some message, Dr. Arun?
No, sir. I just came to attend the OSA talk.
Okay. Thank you.
Thank you.
Dr.